Yes, please do.
Thank you, sir. So thank you and welcome everyone for joining this webinar today with us. I am Dr. Amit Borse, Senior Product Manager with IVA, a division of Emcure Pharmaceuticals Limited, a pioneer in the field of gynecology and IVF. We at Emcure are on a mission to nurture and support 28 days, with Programming 28 as a scientific theme for this year. Programming 28 is based on the concept of managing ovarian cycle with GnRH analogs, gonadotropins and hormones as per different protocol. We are happy and obliged that Dr. Gautam Khastgir sir, our faculty for today, Medical Director, Birth and Advanced Fertility Center, has given us an opportunity to be the academic partner. He will be guiding us on the topic Fertility Enhancing Endoscopic Surgery. Although sir does not require any introduction, but as a matter of protocol, let me read out his CV for you. Dr. Gautam Khastgir sir is a recipient of Well-Being Research Grant of RCOG London. He has published many research papers in infertility, hormone therapy, and endoscopic surgery in international journals. RCOG accreditation of subspecialty training in reproductive medicine and surgery, and level 3 endoscopic surgery. Sir is a medical director of Birth and Advanced Fertility Center. He is a head of gynoscopy, provided hands-on training to over 250 doctors in gynecological endoscopic surgery. Sir was an organizing secretary of ISAR 2018, chair-elect of ISAR Bengal. Sir is an elected member of ISAR Executive Committee for 2020 and 2022. May I now request Dr. Gautam Khastgir sir to give an opening note and share his presentation to continue this webinar. Please, sir.
Thank you very much. Thank you for that very kind introduction, Dr. Amit. Now, I'm really grateful to Emcure Pharmaceutical for taking this initiative and giving me the opportunity to share my views on this very important topic in the field of infertility. Now, when we started our medical career a long time back, about 40 years back, then the whole infertility, as I say, was basically giving vitamins and clomiphene and ask the patient to come back in 6 months, 12 months, years time, 2 years time, so that we hope that eventually many of them will actually get pregnant on their own. Sorry about that. Now, what we found that we could do medical therapy with clomiphene and nothing else, and we could do surgical therapy with laparotomy for tubal surgery. And this was our beginning of infertility training. And believe me, at that time in Calcutta Medical College, which is the Asia's premium medical institution, the first medical institution of Asia, had a separate obs and gynae department called Eden Hospital, and we were trained there. In that premier institution, we had an infertility clinic which used to open only twice a month. So every 15-day, one infertility clinic, and hardly 10-15 patients used to be there. And most of the consultants were not going there. We used to send the junior doctors, and we used to take cervical smear to do spin Burkitt test, semen analysis, and writing these medicines. And some of these patients will get admitted for laparotomy and tubal surgery. And believe me, majority of them, we will never see them pregnant. So it was a challenge for me to take infertility forward from there. And the same year, the first test tube baby was born in 1978 when I started my medical journey. And in last 40 years, the infertility management has evolved so much that now we call it, a discipline is called reproductive medicine and surgery. So we can treat patients with medicine, we can treat patients with surgery, and majority of this surgery are done through endoscope, which I'm going to talk to you today. And we have a huge number of assisted reproductive technology therapies which we can offer to our patient. So now we have like obs-and-gynae, infertility or reproductive medicine and surgery is a separate subspecialty within obs-and-gynae, and people are doing fellowship, people are doing DM, MCH, so many things. So we have come a long way, and we will take it even further. In future, robotic surgery is going to take a great role in infertility practice. Now today, I'm going to cover fertility enhancing endoscopic surgery. So what are the procedures we can do to improve fertility potential of a woman who has come with the problem of infertility? Now, I will just put my talk there, and okay, you can see. Can everyone see my PPT?
Yes, sir. We can see your
PPT?
first slide very well.
Okay, thank you very much. Thank you. Now, are you going to change the slides for me, or I'm going to do it myself?
You can change the slide since it is.
The slides are not changing. I'll just take some help from my colleagues here.
Yeah.
Just give me 1 minute.
No problem, sir.
I'll just try once.
No problem, sir. Great. So
if I stop this.
Yeah, you have stopped this.
Can you see now?
No, sir. Not yet. We can follow the same process. Press share screen button.
Have you seen it? Is it there now?
Yes, sir. You can go to first slide and make a slideshow full screen.
Right. Yeah. Yeah. Is it there?
Yes. This is your first slide. We can see full screen. Great.
Okay. Sorry about this hiccup, but now we are all set to take you through the fertility enhancing endoscopic surgery journey. Now, I will start with the causes of infertility and role of endoscopic surgery. In female infertility, we have the ovarian factor, we have tubal factor, and uterine factors. In ovarian factor, all of us know we have polycystic ovarian syndrome, which is a common problem. Patients present with ovarian cyst and endometriosis. In tubal factor, we have pelvic inflammatory disease, post-operative adhesions, and reversal of sterilization. In uterine factor, it could be a fibroid, it could be a polyp, it could be adenomyosis, and different uterine anomalies, Mullerian duct anomalies like septate, biconjugate uterus. We may have uterine adhesions following surgery, like that of Asherman syndrome. Now, these is a big list, and all of these problems can actually be settled by endoscopic surgery. Now, I'm going to take you one by one. Now, first of all, we need to understand why we are doing endoscopic surgery, particularly in infertility, and not open surgery as we used to do long 30, 40 years back. Endoscopic surgery gives minimum tissue damage because we are not exposing the interior of the abdomen. There is less chance of dehydration. There is less chance of exposure to the exterior, to the environment. So less chance of tissue damage. Much better hemostasis. We can do microscopic hemostasis because on endoscopic surgery, the pictures are far more magnified. Again, Because of lack of exposure to the exterior, there is minimum chance of infection. We are operating through three or four minute holes through which we use choker cannula. So we don't even introduce our hands, no glove particles, nothing else. Our respiration, any environmental thing is going inside the abdomen. And because of all this, minimum tissue damage, less dehydration, better hemostasis, and lower infection altogether results in much lower postoperative adhesions. And in infertility, we really do not want further adhesion following surgery, so that fallopian tubes can move on their own, ovulation can take place, and that is why reduction of adhesion is very important, and endoscopic surgery can give us that benefit. Now, there are limitations of endoscopic surgery as well, particularly those patients who had several laparotomies in the past, those who had abdominal tuberculosis. Because of this extensive adhesion with tuberculosis and with laparotomy, sometimes we cannot do a pneumoperitoneum and go inside the abdominal cavity. Same is the problem with morbidly obese patient. Other day I was doing a laparoscopic ovarian drilling on a woman more than 100 kilo, and her anterior abdominal wall was so much thick that most of the choker cannula were not actually reaching inside the peritoneal cavity. So we need longer instruments, and sometimes it is a surgical risk to operate on these obese patients, to put them on Tendelberg position when the anesthetists are not very happy. So very severe morbidly obese patient may have problem with laparoscopy. Not necessarily we should say that we should not do it, but this role is limited. The next issue with endoscopic surgery, which is not so much now, but in earlier days when we started, the instruments were very expensive and the maintenance of the instruments were actually difficult. But now, with more use, now many of these instruments, hand instruments, are made in India, so they are much cheaper than before. And even the instruments from the foreign companies are available at a much lower rate. India being a big market, India being such a big country with so many doctors using this surgery, now foreign companies would also like to give the instrument at a much lower rate so that they can increase their sale. Now finally, the problem of endoscopic surgery is relatively steep learning curve. When we are doing an open surgery, our seniors can hold our hands and show us how to do things, where to put the clamp, how to suture it. Whereas with endoscopic surgery, it is not possible like that. So holding hand is not possible. So one has to learn by observing videos, by observing others' operations, and also by practicing on dummies. So we have endo trainers. We have like machines where we can practice on this machine with the help of hand instruments, and we can use different dummy material. We can use tissues like pieces of chicken, or we can use some botch piece, which we can cut, we can repair, we can stitch. And also now we have computer assisted simulators. So a computer shows us all the organs, and when we are operating, how we are doing it, how perfect our surgery. So computer can even grade us depending upon. So the technology is so advanced, the steep learning curve is gradually getting less steeper, and youngsters are learning it so well. And I really appreciate their effort and their interest in this field. Now, if we look at ovarian pathology, first of all, we can do laparoscopic ovarian drilling, which can be done for, polycystic ovarian syndrome patients who are not responding to usual clomiphene or letrozole therapy. So this is like a second line treatment. But those who are happy with gonadotropin injections, they do not need to go through the surgery. So our practice is like, if a patient who is not responding to clomiphene or letrozole, as a second line, when we decide the treatment, we ask the patient, where are they coming from? If they are coming from far away, it will be difficult for them to come regularly for follicular monitoring. So then we ask them to go through surgery, because once you have done the surgery, the chance of ovulation is much higher. So they do not have to come at a regular intervals. But those who are happy to come at a regular interval and also bear the cost of gonadotrophins, And with gonadotropin, we cannot guarantee that they're going to get pregnant on the first cycle. It may be the second, third, or fourth, or even longer. So the cost will pile up. So many patients say, okay, we can bear the cost of laparoscopic ovarian drilling and not several attempts of gonadotropin. So what we do under laparoscopic guidance, we make 4 to 6 holes in each ovary using 40 to 60 hertz of energy with 4 to 6 seconds. So the idea is to use diathermy hook or diathermy needle introduced through the cortex with cutting current, with cutting energy, and going inside use coagulation, because we want to actually coagulate or make damage in the ovarian medulla, not in the ovarian cortex, because all the follicles are in the ovarian cortex. Ovarian medulla is producing testosterone. So if we can reduce the androgens from the ovarian cortex, ovarian medulla, then the chance of spontaneous ovulation actually gets better. We can also do surgery for endometriosis, be it with diathermy, be it with bipolar, be it by excision or by laser vaporization. Of course, laser is expensive, so majority of centers in India are unable to use laser, but definitely with diathermy and with excision, we can treat surface endometriosis. When we have ovarian endometrioma or other cysts of ovary, we can remove the cyst, we can use diathermy at the base, and after removing the cyst, we can reconstruct the ovary by suturing. So a couple of days back, I operated on 2 patients with bilateral ovarian endometrioma. One patient was in her mid-30s, and other one was actually a teenager, only 17-year-old. And it shows that we were told earlier that endometriosis is an illness of 30s and 40s, but that is not always correct. Endometriosis may present even in a teenage girl. Particularly with Mullerian abdomen, it is very common, but even if with normal pelvic anatomy, endometriosis are being presenting in young individuals much more than what we used to see earlier. And in both these moments, our surgery was different. In a young woman, we had to remove her cyst and reconstitute her ovaries, so keep her ovaries as much as possible. In the other woman who was in her, like late 30s and early 40s, her AMH level was already very low. So much so that she was happy to have donor egg for her future fertility treatment. And in that case, I was very happy to remove one of her ovaries, which was almost covered by endometriosis, and the endometriosis cyst was very big. So depending upon patient's age, patient's parity, other reproductive profile, we decide whether to do ovariotomy, that is removal of the ovary altogether, or ovarian cystectomy. Now, when we do ovarian cystectomy, it is very difficult to remove the cyst altogether because it is a pseudocyst. So with laparoscopically, we separate the maximum portion of cyst wall, and the base is actually coagulated, because if we want to remove the cyst from the base, it bleeds quite heavily and it takes away some of the normal ovarian tissue, which I'm going to discuss further in my subsequent slides. Now, this is a picture of how we do laparoscopic ovarian drilling. Because of shortage of time, I'm not going through the video, but I will put all these videos on Facebook so that you can watch these videos later. Now, when we do laparoscopic ovarian drilling, basically, it's all started with the view that traditional wedge resection, which was done long time back by Stein and Levelthal, it was stopped because that wedge resection gave lots of adhesion and it required a laparotomy. But with modern age, laparoscopic surgery took over by ovarian drilling. We can do either monopolar or we can do bipolar. Now, recently a new technique called ultrasound guided transvaginal ovarian drilling has come up. It is not very popular as yet in India. We can also do laparoscopic ovarian multi-needle intervention therapy. So multiple puncture done, no energy used. But the standard procedure is with monopolar energy. And as I said, 4 to 6 punctures, 40 to 60 watt, the diameter of 1 to 3 millimeter, depth of 4 millimeter, and the time interval should be very short because we really do not want to destroy the ovary. There are few reports of premature ovarian failure following this surgery. But I always say that those are the cases where the case selection wasn't done properly. Maybe this patient really didn't require laparoscopic ovarian drilling. They didn't have polycystic ovary. What they had was rather multicystic ovary. So several cysts, but not other feature of polycystic ovary. And maybe the surgical techniques were not done properly. There was more damage on the cortex, and and that is why the ovarian function was low. Now, next, what we see that we can use different type of energy, electrocoagulation or laser vaporization. And what we see, the ovulation rate and the pregnancy rate are very similar. Rather, with electrocoagulation, the results are much better because electrocoagulation causes more damage to the ovary rather than the laser. And laser is preferred because there is less postoperative adhesion on the ovarian surface. But as I already mentioned, that laser is not available for everyone across India. Now, the mechanism of action of laparoscopic ovarian drilling, there is decrease in the circulating level of androgens, both dehydroepiandrosterone sulfate and testosterone. Now, some people think it's just puncturing the follicles we are getting result. That is not the case. It is by destroying the ovarian medulla, by reducing the androgen, the further ovulation is enhanced, and not by puncturing the unruptured follicle. What we have found that it will reduce in PCO. We know the estrogen level is very high. Following surgery, the estradiol level diminishes. It is also seen that LH, which is very high, in PCO patient, that level will also be low. It is also shown that there is decrease in inhibin and AMH level. And we know AMH level is very high in PCOS, unlike endometriosis where the AMH level is actually low. So in PCOS, if it is very high, reduction of AMH actually helps in ovarian sensitivity. Those ovaries work better actually later with subsequent ovulation induction. Asia and ASRM develop a consensus. They said laparoscopic ovarian drilling can achieve unifollicular ovulation, which is not so with clomiphene and gonadotrophin. Letrozole gives unifollicular ovulation, and so does laparoscopic ovarian drilling. And therefore, there is no risk of ovarian hyperstimulation syndrome and no risk of multiple pregnancy. However, the other great advantage is with this treatment, we do not need intensive monitoring of the follicular development by serial ultrasonography, which may be difficult for people coming from remote areas, from rural areas, and also it is expensive. So gonadotrophin, it's expensive medicine and requires lots of monitoring, which increases the cost. With laparoscopic ovarian drilling, one-off expense, and subsequently they don't need monitoring. And therefore, it is a better alternative than gonadotrophin in many patients. It reduces the direct and indirect cost. As I said, direct cost by reducing the cost of the medicine, and indirect cost by reducing the cost of monitoring. So what are the indications of laparoscopic ovarian drilling? We should do it for clomiphene resistant patients who are not responding to clomiphene citrate, those patients who require laparoscopy for some other purpose, maybe for tubal surgery, those patients who are not responding to clomiphene, letrozole, gonadotrophin, they are not responding. So it should be used as a second line for ovulation induction in PCO. But we know by several studies, it is as effective as gonadotrophin, as effective as letrozole therapy. And I'm reiterating that if you have an outpatient couple who are coming from far away, they are someone who are very suitable for laparoscopic ovarian drilling. Now, I believe there are many reproductive specialists who doesn't like laparoscopic ovarian drilling because they think it destroys more ovarian function rather than benefit. I'm not saying this is the only treatment for PCO. Of course, if we can treat these patients with gonadotrophin, definitely that is a good choice. But believe me, in my long career, I've found that many patients do not have the capacity or do not agree with your opinion because of their geographical situation and because of their economic limitations. The limitations of laparoscopic ovarian drilling are A, it requires general anesthesia. There may be thermal damage to the surrounding organs. And because of this, there can be peri-ovarian and peri-tubal adhesion, because if the surrounding fallopian tube, intestine, omentum had thermal injury, they will come and get itself attached to the ovary. And because of this adhesion, subsequent fertility chances are low. I've already mentioned there may be damage to the ovarian reserve, leading to ovarian failure, although it's very, very rare. Risks and morbidity with obese patient had already been covered with my personal experience. And therefore, often what happens is, suppose someone has done a laparoscopy for a diagnostic purpose. Not other backup testings have been done. And the ovaries look little cystic. And doctors usually say, okay, let's go and do laparoscopic ovarian drilling. So for indication, the threshold is very low. You have gone inside, you feel like you do it, and that is sometimes not correct. All patients should have regular, thorough investigation in terms of their ovarian potential before going for this surgery. If we compare, laparoscopic ovarian surgery is better than metformin. It is equal to clomiphene and letrozole and equal to FSH and HMG. These are from the international evidence-based guideline for the PCO patient published in 2018 and 19. Now the next is laparoscopic surgery for endometriosis. Now on this slide you see, on this picture you see, both the ovaries are stuck on the pouch of Douglas behind the uterus at the level of uterosacral ligament. And we are using bipolar energy, bipolar diathermy forceps to separate the ovaries. And once we separate the ovary, sometimes we find cyst underneath the ovary. Now from this ovary, obviously the ovulation cannot take place because it is stuck, and the egg pickup is also not possible with the fallopian tube. Now, what happens with endometriosis? Laparoscopic surgery is also the mainstay for the diagnosis and management, because without laparoscopy, you cannot ideally diagnose endometriosis. So endometriosis has to be diagnosed by laparoscopy and by taking a biopsy. But that is not happening nowadays. Nowadays, we have very good ultrasonographic facility which can pick up adherent ovaries, which can pick up endometriosis, and with good medical therapy, we can treat this patient, what is called therapeutic challenge or pharmaceutical trial. So if someone has premenstrual pain, dysmenorrhea, dyspareunia, you can put this patient on some medical therapy, suppress their ovarian function, and see if they are responding. If they are responding, that their dysmenorrhea is because of endometriosis and not because of pelvic infection or something else. But having said that, the popularity of this surgery are often supported by uncontrolled studies. So not like, you diagnose a patient of endometriosis, on one group you do medical therapy, other group you do surgery, and then compare the result. It's not done like that. Medical therapy didn't work, you do surgery. And so often the papers are biased. They actually report those cases where the results were better. What has been found that patients of endometriosis have a background pregnancy rate with any problem of infertility other than like tubal block and azoospermia. The problem is relative. So even a patient of endometriosis, a patient of mild infertility, unexplained infertility, can actually get pregnant without any treatment. So if we do surgery, our success rate improves by only 10 to 15%, which sounds very small, but even 10 to 15% may be tremendously good for many patients. But now with the advances of assisted conception, everybody is saying that the role of surgery in endometriosis should be reviewed. We should really think about it, how much surgery we should do before or after or as an alternative to assisted conception therapy. I'm going to cover that in subsequent slides. What are the aim of endoscopic surgery for endometriosis? We want to actually excise or fulgurate all visible endometriotic lesions, because even small spots of endometriosis can actually release toxins, and these toxins are bad for the egg and sperm. Now, advanced endometriosis will have lots of adhesion, anatomical distortion. So we need to restore the normal pelvic anatomical relationship, particularly around the fallopian tube and ovaries. And we need to remove severely diseased, non-functioning organs. So as I told you, in one of my patients, there was absolutely no ovarian tissue in one side. And because she was elderly and happy to go for ovum donation, I could remove that diseased ovary. Otherwise, the diseased ovary would have reduced the chance of pregnancy rate in my patient. And finally, we must try our best to prevent further adhesion formation, which is very common after endometriosis surgery. We can use heparinized normal saline. So after the surgery, we leave some fluid in the pelvis so that organs can actually float and prevent adhesion. We can use Intracid, and we can use different other methods of suspending the ovaries higher up with the anterior abdominal wall so that they don't fall back and get themselves adherent, attached to the posterior wall of the uterus. So the aim of the surgery being multifaceted, multifold, we also need to see that endometriosis can come in different shape and size. Endometriosis is not one disease. It is 3 different disease entities. And these slides show surface endometriosis. Small vesicles over there, white lesion, flame lesion, brown spot, yellow spot. So not necessarily endometriosis is always like dark brown spots or black spots or blue spots. They can be yellow, red flame, or white spots as well. Now, ideally, we should take a biopsy from there and confirm endometriosis, which is not always possible. But by doing a diathermy on the lesion, we improve the result. Next, it could be an ovarian endometrioma, a cyst formation within the ovary. And here you see after diagnosing it, after draining the chocolate material, the cyst is removed, and often the ovaries are reconstituted again to bring back to their normal shape and size. And finally, it could be a rectovaginal endometriosis in the pouch of Douglas. So this is the uterus and this is the rectum. So there is a nodule there and it's being dissected and removed. And this relieves pelvic pain. Many of these women have severe deep pelvic pain and severe dyspareunia. They cannot have intercourse at all. So this deep endometriosis do not have direct effect on infertility other than deep dyspareunia, which prevents them having natural reproductive life. Now, in order to decide what type of surgery, we divide our patients into 2 groups, mild and minimal endometriosis in one group, moderate and severe endometriosis in another. In mild and minimal endometriosis, there have been several randomized control trials. They were in randomized control trial, and there have been 2 well-publicized randomized trials. One is called Canadian study or EndoCan study, and other one is an Italian study. Now, Canadian study showed in one group, if you do laparoscopic treatment of endometriosis versus you do not do anything, you just diagnose and come out, the success rate is much higher by surgery, 36% in comparison to doing nothing. So even if you do not do anything, the success rate is as much as 20%. And the Italian study showed whether you do anything or not, the results are always same. And what is very important is number needed to treat is 12. So if you do surgeries for 12 patients, only 1 will get pregnant. So for one surgery, you need to treat 12 patients, which some people are saying, is it worth doing it? Suppose you have done a diagnostic laparoscopy, you have found endometriosis, you have done treatment, that is fair enough. But with all patients of infertility and endometriosis, if you ask them to go through laparoscopic surgery, perhaps that is not right because number needed to treat is too high. We have compared laser surgery and diathermy surgery. There is not much difference in the pregnancy rate. And some people have tried excision, and we compared with electrocoagulation. Again, the success rate is very similar. So the ESHRE guideline is like this: operative laparoscopy with adhesiolysis along with excision and ablation of endometriosis should be done rather than diagnostic laparoscopy for improving the spontaneous pregnancy rate. So European Society guideline is telling that if you have done a laparoscopy, just don't come out. You separate the adhesions and remove, excise or ablate the endometriosis. However, having said that, complete surgical removal of endometriosis to improve live birth rate with ERT is not well established. So suppose someone is going to have an assisted conception, say IUI or IVF. Just by doing a surgery, you are not going to improve the success rate of ERT. So with this sort of findings, many people are saying, wow, why should we do a surgery? We can straight away go for assisted conception. But it is again true, not everyone can go through assisted conception. Now, if we look at moderate to severe endometriosis patients come with lots of pain in the lower abdomen. They have lumps in the lower abdomen, the swelling and pain. And it is unfair, unethical to randomize this patient, one group having surgery and one group having medical treatment. That is not fair because they need the surgery not only for infertility, but also for the relief of pain and relief of their discomfort. So many a time endometriosis patients have hydronephrosis. The ureters are strictured. So we are doing the surgery not just to improve the infertility, for other benefits as well. So there is no randomized controlled trial or meta-analysis between surgical therapy and non-surgical therapy. It is true that many surgical therapies have shown very good result between 30 to 60%, but these are studies before the millennia, and we have always known that those people having good result present their result, and those are having not good result, they usually do not publish. So good result is biased result unless it's a randomized controlled trial. So what is currently found, that success rate is about 25%, which is not bad, and very importantly, number needed to treat is only 4. So if you treat 4 patients, one of them will get pregnant, and that is very good. That is very fair. So even with mild endometriosis, we are not doing surgery. With moderate to severe endometriosis, endoscopic surgery has a very important role to play. Now, there is a negative correlation between the stage of endometriosis and the success rate after surgery. That is obvious. That is obvious. More severe the endometriosis, more severe the damage, lower the ovarian function, the success rate will be low. But less the endometriosis, success rate will be better. As regards the efficacy of surgery, we know conservative surgery is better than no treatment. I've already said adhesive disease where the structures are adherent or endometrioma is more than 4 centimeters, we should go for surgery. Cumulative pregnancy rate varies between 35 to 60%. With moderate endometriosis, cumulative pregnancy rate each time success rate may be 10%, 20, 15%, 20%. But if they try for 6 months or 1 year, 60% of this patient will get pregnant, and 35% of the severe endometriosis patient will get pregnant. And pregnancy usually comes in the first year after surgery. So 1 year has gone by, they are not pregnant. Perhaps we should think of other treatment like assisted conception, because the chance of pregnancy actually goes down. And most importantly, there is very, very little role of repeat surgery. So someone already had a surgery, either by the same team or by a different team. Please do not go ahead and do separate repeat surgery to improve reproductive function, to improve infertility, to give relief of infertility. It may be relief of pain, but repeat surgery doesn't improve fertility potential. And this is something I'll be repeating again and again and again, because all the papers are now saying against repeat surgery. ASHRAE guideline similarly has said that excision of the endometrioma capsule should be done rather than drainage and coagulation. So in one slide I showed you the endometrioma, if you just drain it, drain the chocolate color fluid and coagulate the surface, the chance of recurrence is very high. Whereas when you separate the endometrioma capsule, the success rate is much better. If the endometrioma is very big, it helps in accessibility of the ovary, so we can actually collect the eggs much better. And surgery for endometrioma has the risk of reducing ovarian function and possibly loss of ovarian function, particularly those who had previous surgery. There is no effectiveness of deep nodular endometriosis except pain relief. If there is associated hydrosalpinx, we usually remove the fallopian tubes, clip the fallopian tubes, so the chance of assisted conception improves. Now, it is interesting to note that 75% of women with endometriosis who had multiple failed IVF came for surgery, and 68% of them became pregnant. Although it's a not randomized trial, although it's a not meta-analysis data, but still observational studies have their important role, and these facts cannot be ignored. When it's an ovarian endometrioma, excision is much better. Partial cystectomy and ablation of the remaining cyst wall. Success rate of the surgery to improve fertility is actually modest. And with endometrioma, not other endometriosis, with endometrioma, number needed to treat is again very high. If you are treating 40 patients, only one of them will get pregnant. Endometriosis surgery has a negative impact on the ovarian function. So now many doctors are saying less is more. Now it's interesting that many people identify me as a laparoscopic surgeon and others call me assisted conception specialist. Now myself, who has the ability to do both, have actually gone more from endoscopic surgery to assisted conception in cases of endometriosis, because the pendulum has shifted on the other side, where we all believe less surgery is actually better. More harm than benefit are being done with laparoscopic surgery in endometriosis. Now, why? First of all, there is an absence of plane of cleavage between healthy ovarian tissue and the cyst. So in 97% of the cyst sample, we actually find healthy ovarian tissue. So very happy that we have removed the cyst, but we have also taken away some healthy ovarian tissue. And there is a direct proportional relationship between the size of the cyst and damage to the ovarian function. We also do coagulation to control the bleeding, and that damages the blood supply. So ovarian reserve, whether we check it by AMH or antral follicular count, it has been found that ovarian reserve diminishes after surgery. And women with endometrioma, they may have a low AMH level, and after surgery, the AMH level reduces further. But in some patients, it will again get back to normal. In a bilateral endometrioma, AMH level compared to a unilateral ovarian endometrioma may not give a correct result. So antral follicular count is often better. So the bottom line is, whatever surgery you do, some ovarian function will be diminished. But if some women have good ovarian function, why not? You can go ahead and do surgery, particularly if it's a unilateral, other ovary being normal. Yes, definitely ovarian reserve won't be hampered. So our indication for surgery in infertility, in summary, is in mild to moderate endometriosis. Suppose you have done a laparoscopy, you can treat, but not like planned surgery for all mild to moderate endometriosis. If we have treated by ovulation induction, they are not successful, they can opt for laparoscopy or assisted conception. Not every patient has to go through laparoscopic surgery. All type of endometriosis patient with pain will actually get benefit from surgery. So surgery should be done unless the ovarian function is so poor that surgery is going to damage further. So we give some medical therapy for pain, complete assisted conception, and then do surgery for a relief of pain. Hydrosalpinx I've mentioned, improve egg collection I've mentioned. Now many individuals will not agree ART either due to personal reason or due to social reason. So in all these moments, we actually need to do surgery. So in summary, mild to moderate endometriosis patients will actually benefit, and the younger patient benefit more. In moderate to severe endometriosis, we need to do surgery to normalize pelvic anatomy to relieve pain. Cystectomy should be done if the cyst is more than 4 centimeters, but in elderly patient, sometimes we should go straight away for IUI or IVF rather than surgery. So the take-home message is infertile patient with endometriosis will benefit from laparoscopic constructive surgery. The need for surgery has to be individualized, depending upon the symptom and the stage of the disease. The efficacy of surgery of minimal endometriosis has been confirmed by randomized controlled trial and meta-analysis, but the role of surgery to moderate to severe endometriosis is limited and may be detrimental in some. Now let's come to the tubal factor. Now the tubal problems could be pelvic inflammatory disease, could be post-operative adhesion, could be reversal of sterilization. Now we can do salpingolysis, ovariolysis, salpingostomy, hysteroscopic cornwall cannulation. We can do coagulation and excision of post-operative adhesions. We can do reversal of sterilization with micro-laparoscopic instrument, although it has to be done in the hands of the expert. Not all laparoscopic surgeons are very good at it, and case selection is very important. If the ligation is done at the time of cesarean section, but a large proportion of the fallopian tube is removed, those are the very difficult cases for reconstitution. Now, this is a laparoscopic picture showing bilateral mild hydrosalpinx where salpingostomy was done. And again, this video will be available on Facebook. You can watch them later. Now, many people are actually debating whether there is a role of tubal surgery at all in the era of assisted reproductive therapy. So the American Society of Reproductive Medicine published this guideline, which basically said that in limited cases, it still has a role. Hydrosalpinx, once it's diagnosed, the diagnosis can sometimes be incorrect. The sensitivity and specificity, as you will see, is low. Those hydrosalpinx which are visible on ultrasonography can actually undergo laparoscopic surgery. It will, or it has to be treated laparoscopically to improve the chance of ART, improve the chance of IVF. So laparoscopic tubal clipping or partial salpingectomy can be done, or sometime if the hydrosalpinx is mild, we do laparoscopic salpingostomy. So if a patient of hydrosalpinx comes, we do a laparoscopy, and depending upon the extent of the disease, because in severe hydrosalpinx, the cilia of the fallopian tubes are actually destroyed. So although you open up the fallopian tubes, they are structurally open but not functionally good. And many a time there is chance of ectopic pregnancy in these poorly functioning fallopian tubes. We know several studies have shown that hydrosalpinx should be treated before IVF, because otherwise this fluid may mechanically flush the embryo. It will reduce the endometrial receptivity, and this fluid may have direct embryotoxic effect. So treatment of hydrosalpinx is very important. Now, there are many uterine defects for which we need to do endoscopic surgery. If there is a submucous fibroid, we can remove it hysteroscopically. We can hysteroscopically divide Asherman syndrome, and we can divide uterine septum. We can use monopolar, we can use Varsa point, we can use simple scissors. So diagnostic hysteroscopy is very important for unexplained infertility, for uterine anomaly, prior to IVF, repeated IVF failure, suspected endometrial pathology, in cases of recurrent abortion, and in abnormal uterine bleeding. Operative hysteroscopy is required for polyps, for submucous fibroid, septum, adhesion, misplaced IUCD, and for hysteroscopic cornwall cannulation. Now I will go through some pictures very rapidly. You can find small tiny endometrial polyp detected by hysteroscopy which would have been missed by DNC. This is acute endometritis. This is retained products of conception. You can see small fetus, you can see fetal bone, and other gestational material. Forgotten IUCD, these are all causes of infertility. We can detect intrauterine septum. We can resect this septum with diathermy. We can identify small submucous fibroids, large fibroids, and we can also operate them with bipolar energy, with bipolar look, with unipolar energy. Now, this is a picture to show which are the cases we should opt for hysteroscopic surgery. If the fibroid is largely on the submucous side, then we can resect them. But if it is completely intramural as well as submucous. When we cut them, what happens is this intramural part will protrude. So we have to shave, cut, and sometimes there is a risk of uterine perforation. So we need very good ultrasonography, sometimes even MRI to locate the position of the fibroid. Intrauterine adhesion following surgery, following myomectomy, following termination of pregnancy can be detected, can be treated. Hysteroscopic tubal cannulation. So we use this tubal cannula and then with the help of the cannula, we can correct the obstruction and push the dye. So hysteroscopy has an important role to play, and it is gold standard for the diagnosis of intrauterine lesions. We can do uterine septum metroplasty. I'm not going into the details of the statistic because of the shortage of the time. We can do adhesiolysis, and following adhesiolysis, sometimes we introduce an intrauterine device and give estrogen replacement for 3 months. Prognosis is not very good for tuberculosis and those patients who previously had multiple procedures, but with flimsy adhesions, the results are very good. With chlamydia infection, the results are very good. In T-shaped uterus, we can use metroplasty, lateral metroplasty, and improve the results. Proximal tubal obstruction, many a time it is because of fibrosis and because of cornual polyp, but the remaining 30%, just some viscous material, amorphous material gets stuck and can easily be overcome with the help of hysteroscopic cornual cannulation. Removal of the polyp is very helpful, particularly before IVF, and hysteroscopy before ART plays a very important role. We are not doing it as a routine because of cost. Sometime after the first failure, we do hysteroscopy and we check the endometrium for TB PCR and bacterial culture just to identify the cases of endometrial tuberculosis, which could be the cause of infertility. In patients with recurrent pregnancy loss and abnormal hysteroscopic finding, hysteroscopy may result in spontaneous pregnancy or improve the chance of ART. Now, we can also do laparoscopic myomectomy, where we remove the fibroids from the uterus, and this fibroid removal is just like open myomectomy, and after removal of the fibroid, we stitch up the uterus so that we reconstitute the uterus and improve the chance of pregnancy. Now, laparoscopic myomectomy, laparoscopic approach is much better because the post-operative cure is much higher, there is less morbidity, rapid recovery, but not always suitable if there are multiple fibroids and large fibroid, and suturing skill is very important. Now, there is a theoretical risk of fibroid morcellation because of the reports of sarcoma being spread, but we can identify these cases very carefully and we can do in-bag morcellation now to prevent this risk. Now, if we take all the fibroids, then we have to understand it very clearly that all fibroids does not require surgery. If it's a submucous fibroid, there's significant impairment on the fertility potential. And after surgical intervention, there is significant improvement. And we also need to do it because many of these patients have abnormal uterine bleeding. So what we do, we resect them hysteroscopically. If it is an intramural fibroid or more than 4 centimeter, then there can be significant impairment as well. But preferably, we should do it laparoscopically because I showed you in that picture that unless, if we try to do it hysteroscopically, there is increased risk of uterine perforation. If the intramural fibroid is less than 4 centimeter, the jury is still out. We do not know whether it really causes any damage or not. So many people are not actually operating on them. Having said that, if you have a patient who is having repeated implantation failure, good embryo being transferred but still not getting pregnant, those are the cases where even the small fibroids may have to be removed. But subserosal fibroid, definitely there is no need of surgery for this patient. Now finally, I will talk about adenomyosis, which is a big problem in the field of gynecology and infertility. we understand very little and we have very little effective management. But adenomyomectomy can help in infertile patient. Now, once what we have find is if we find all the routine investigations are normal, ovarian reserve test are normal, we can put this patient on long agonist protocol and go for assisted conception. But if we already see these tests are poor, this ovarian function is poor, then instead of this, we straight away go for IVF. If there is a natural conception failure or failed IVF, then we do repeated IVF on these patients. But it is only with failed IVF, we do conservative surgery, that is conservative removal of the endometrioma, and then repeat IVF after 3 to 6 months. The problem with adenomyosis is adenomyosis doesn't have a capsule. So unlike fibroid, it is very difficult to remove it. And also, while removing it, we may damage the endometrium. So there has to be some tissue, some myometrial tissue between the endometrium and adenomyoma, and also between adenomyoma and the capsule. And that is why often what happens is we decide how to do it depending upon the type of adenomyosis. So if it is a localized adenomyosis, then we can do this surgery either by laparoscopy or by laparotomy. But if it is a diffuse type 2, then most authors have decided that it is better done by laparotomy. Because what we need to do is we need to keep good plane of healthy myometrium, or at least some myometrium from the endometrium, and repair it so well, otherwise the chance of pregnancy will be low, and even if pregnancy takes place, there will be chance of uterine rupture. Now, here is a role of robotic surgery, which in future I'm sure is going to play a great role, because with robotic surgery, adenomyosis or deep-seated endometriosis can actually be treated better. Now, what we have decided that we have decided these two types, and we have categorized them according to their different techniques. That type 1, which is localized, the surgery is much easier, the risk of entering cavity is low, risk of destroying functional myometrium is low, maintenance of uterine integrity is good, rupture uterus is low, symptom control is much better, and fertility preservation is higher. Whereas with diffuse endometriosis, they are not really very well. So if you have a patient with diffuse endometrioma as adenomyoma, sometimes you have to really think whether you're going to benefit. Of course, with pain relief, it will be good. But for fertility potential, you need to really think whether it's going to help or not. And if it is really surgery is required, here is a type where laparotomy will be actually helpful. So ladies and gentlemen, I would like to conclude by saying that hysteroscopy plays a very important role in reproductive outcome of infertility patient. Particularly those with recurrent abortion, it is more helpful than those with infertility. We can do polypectomy, metroplasty. It has better prognosis with submucous fibroids. Endometrial healing time and new adhesion formation has to be supported by some form of treatment. There is no proven method of enhancing the healing process. The repeat surgery may be needed for submucous fibroid, thick intrauterine septum, polyp, adhesion. Your first surgery may not be complete. You may have to go again. Hysteroscopy, irrespective of surgery for intrauterine pathology, even if there is no pathology at all, by just doing a hysteroscopy, the outcome of ART improves, both in new cases as well as failure cases, because this is irritation of the uterus, what we call endometrial scratching. We often pick up endometrial tuberculosis. So even the endometrial cavity looks normal, hysteroscopy actually improves the outcome. Now, as regards laparoscopy and endoscopy in general, it should be the first choice for reproductive surgery, particularly for infertility patient. And I'm a strong believer of the second statement which I'm going to make. Reproductive medicine and surgery should be made available in the same center, under the same roof, so there is no bias for either therapy. Because I've seen in my earlier part of career, many cases were treated by surgery because IVF facilities were not there. And many IVF centers were doing just IVF because they couldn't perform laparoscopic surgery. I'm very glad the current generation are learning both these techniques very well. Cost of the instrument has been an issue, but please remember these patients stay in the hospital for a very short period, lesser need of medicine, and they return back to work early. So that is very important. And the pain relief and the comfort, you cannot put a price tag on this. So obituary of laparotomy for majority of the infertility related surgery is already written. In very few cases, we may have to do laparotomy. Laparoscopy can give patient comfort, quick return to normal life, and many other medical benefits. Now, finally, I will end by making a statement which was initially written by one of my teachers in UK. He said, the endoscopic surgery has opened the door of advantages for the infertility patient, which can never be closed ever. So when I came back from UK 20 years back, I had to spend a huge long time to convince the patient to have an endoscopic surgery. But now, most of the patients come and tell me, I do not want laparotomy. I want surgery and I want laparoscopic surgery. Give me that guarantee. So once you give the benefit of anything in life, people appreciate it and they will be the great supporter. So now the doctors, those who cannot perform endoscopic surgery, are actually learning endoscopic surgery because otherwise patients are not coming to them. So ladies and gentlemen, thank you very much for your time, for your patient hearing. It is almost an hour. Now I'll be happy to answer all your questions. I sincerely thank my team. It's a big team of 75 people working with me, and it is without their help, I couldn't have been here what I am today. I get all the claps, I get all the accolades, but these people actually work behind the scene to make our patients happy. And I also thank NCure and everyone from this organizing team for making it possible. And I look forward to coming back in many such programs in the near future. Thank you very much. Thank you.
Thank you, sir. Thank you very much for this very precise session, and people were loving it. There are a lot of praises in the chat box for you, and there are a lot of questions also. So with your permission, sir, should I go for questions?
Yes, please do. Please go.
So the first question from Dr. Indira Shivakumar, she has put a case, unmarried woman, indication for ovarian endometriosis surgery.
Indication for ovarian endometriosis surgery in unmarried women. In unmarried women, what we do is initially we try with the medical therapy. Now the medical therapy can be in different ways. I used to use oral contraceptive pill continuously, end to end. This is what is called not cyclical, but end to end seasonal contraceptive pill. Like we use OC pill for 84 days. So 4 packets taking one after another and then give 7 days gap. So because of this prolonged suppression of the ovarian function and absence of menstruation, what we find that there is relief of endometriosis. Now we have Dynogest, which works very well in terms of reduction of the cyst size. We can use GnRH analog as well. So once this medical therapy, we can use anastrozole, particularly for adenomyosis and endometriosis. So once these medical therapies have worked for 3 months, 6 months, and if we see that the cyst is not diminishing in size, just like I mentioned about this patient I operated 2 days back, 17-year-old girl with a 9 centimeter cyst on one side and 6 centimeter cyst on one side. Now, what happens is when you have a patient, this young patient, their parents will be mortified if you say you need to do a surgery. They will repeatedly request you, Dr. Saab, please try, do something without surgery. So it is not harmful to give them some medical therapy as long as you are sure that you're not dealing with a malignant ovarian cyst. So we do CA125 and other tumor markers, and we keep them under close follow-up. After 3 to 6 months, if the cysts are bigger, we have to do a surgery. Because what I believe is unless we do the surgery, whatever the residual ovarian function, it will be destroyed. with the cyst pressure. So once you remove this 9 centimeter cyst, still there is residual ovarian tissue, which you can reconstitute. And we have several hundreds pregnancies in last 20 years, young girls who came to me unmarried stage or immediately after marriage, they had surgery resulting in subsequent pregnancy. Surface endometriosis, definitely the effect is there, but for an unmarried woman, suppose surface endometriosis, we usually don't treat them by surgery. So those patients are presenting with pain, and if ultrasonography doesn't show endometrioma, we usually don't operate on young unmarried women.
Thank you, sir. Thank you very much. I hope, Dr. Indira, you got the answer of your question. So there is one more question from Dr. Vandana Shah. Firstly, she is praising you for this excellent presentation. And she's asked a question. Sir, if the patient is planned for laparoscopic myomectomy, then when to plan tubal testing, chromotubation, before or after myomectomy?
I always do it before myomectomy, because before, if you do, you will be staining the uterine cavity. So by any chance, if you open up the endometrial cavity, you can see blue color and you can identify it. Secondly, once you have done the myomectomy and you have done the suturing and everything, often there is extravasation, what I would say, extravasation of dye. So dye may go into the tissue plane. So the uterus will become blue. Rather than building up within the uterine cavity, often it goes inside the tissue plane, and dye test is not always good. Now, I do a dye test at the beginning, and then after surgery, I usually ask this patient to come back after 6 months, 3 to 6 months, and I often do a saline infusion sonography, which is very accurate, very good, and that tells me more about the tubal patency, because even if the tubes are open with fibrosis following surgery, many of these women will have blocked tube. Many of these may be blocked tube because of infection in the postoperative period. So an open tube at the time of surgery doesn't mean open tube after 6 months.
Fine. Great, sir. Thank you for this explanation. Dr. Vandana Shah ma'am has again put a question. Sir, after adhesiolysis, after 1 month of E plus P, no withdrawal bleed, how to manage?
Okay, you need to check the endometrial thickness by ultrasonography. This absence of bleeding can be because of 2 reasons. One, there was very little endometrium left, very little residual endometrium. Why we are giving E and P? Mainly to develop the endometrium. So often you need to increase the dose of estrogen, and dose of estrogen, higher dose of estrogen can be given by estrogen gel. So I often use 5 grams of estrogen gel twice daily, so 10 gram daily, which is a quite substantially large dose of estrogen, which cannot be given orally, because if you give so many tablets orally, these patients often have nausea and vomiting. Often I combine oral and gel together, and maybe we will give estrogen for 3 months and then give a withdrawal bleeding. So there is sufficient time for the endometrium to build up. But having said that, often what happens is endometrium is very thin. Now these are the patients where your PRP therapy, platelet-rich plasma, stem cell therapy, platelet-rich plasma therapy on the endometrium, installation of this may help. Now this is a very difficult field that in my career, I have had several patients where even after repeated hysteroscopy, I couldn't give them menstruation. So if the damage is too much, so at the time of hysteroscopy, you can guess whether this patient is going to have periods or not. It's worth giving it a try. It works in some women, but not all. So I would advise you to increase the dose of estrogen, and sometimes a second hysteroscopy is helpful, because maybe following the primary hysteroscopy, there can be repeated, there can be recurrence of adhesion, and if you separate the adhesions, then sometimes it helps better.
Great. Thank you, sir. Thank you very much. I hope, Dr. Vandana, you got your answer. So one more question from Dr. Indira Shivakumar.
Right.
They are asking a case study basically. 26-year-old married since 6 months. Bilateral multiple endometrioma. What is the line of management?
What are the sizes of this endometrioma?
So they have not mentioned the size of
Okay. So
endometrioma.
I hope if the sizes are small, I will definitely treat them by medical therapy. And as I said, I use a cocktail. I use a combination of 2, 3. So I usually put them on Ocipil and GnRH analog, or I put them on Dynogest and GnRH analog. Sometimes I use anastrozole as well. Now, you have to use drugs which are not going to do much damage. So, like Ocipils are quite safe. And if you give Ocipil along with GnRH analog, then the osteoporosis, issue of estrogen deficiency symptoms are often taken care of. So it's a good combination. Now, you have to give a treatment which is scientifically correct. So there are evidence that endometrioma diminishes or disappears with medical therapy, but it depends upon how big they are. And often what happens is, in practical term, when you're working in a developed country, like USA, UK, Australia, or Europe, there are definite guidelines. So all doctors are actually speaking in the same language. We do not have anything like that in India. So suppose what happens is you tell your patient that, okay, you need surgery. And then patient doesn't stick to you, go to another doctor. 9 out of 10 doctors will say, no, you need medical therapy. This is the reality. So at the end of the day, patient will do whatever suits them. Patient may come back to you. It has happened several times with me. That 3 years later, they have come back. They have been having different treatment with different other doctors for 3 years. The cyst getting bigger and bigger and bigger. And they came back and had the surgery under my care. So recently married, small endometrioma, I would treat them medically, because you have to respect their sentiment. If they have seen other doctors had medical treatment, why repeat? So you have to individualize every case depending upon the medical circumstances, and also depending upon the individual, So medicine is not just a science, it's also an art. And it is our responsibility to understand what patient is thinking about. A patient from a city, a patient from a village are actually different. Although they may have the same illness, they're actually different. Their outlook is different. So I have had patients where they said that I'm coming from the village, an unmarried girl having a surgery, the whole village will know, and this girl is never going to get married. So you cannot do surgery because of social reasons. So at the end of the day, you have to individualize depending upon the medical, social, economical, and other many aspects. And at the end of the day, whatever you are doing, it's correct if you would have done the same for your own family member. And this has been my teaching, that when you are treating a patient, you think it is your sister, your daughter sitting in front of you, what you would have done for that particular cases. And in endometriosis, my teacher also said the cause of endometriosis is not known. The correct treatment of endometriosis is not clear as yet. And that is why there are so many treatments. And he used to tell me 40 years back or 30 years back that besides Statue of Liberty, a space has been kept empty for the individual who finds the cause of endometriosis and the correct treatment of endometriosis. Funnily, he used to say the same thing in pregnancy-induced hypertension lecture, say that pregnancy-induced hypertension, we do not know what is the exact etiology, so a space has been kept free, but that space is still free. 40 years down the line, we still know more than what we used to do, but not everything clear as yet. We are so happy there are so many different medicines coming up for fibroid and endometriosis, and many new treatment for PIH. So I'm sure the future is very bright.
Thank you, sir. In fact, I'll say thank you for that Guru Mantra, what you are giving to everybody of us. So one more question from Dr. Saswati Sanyal Chaudhary. She's asking, after hysteroscopic myomectomy, Any
Yes.
intervention for preventing synecdoche?
For preventing adhesion?
Adhesions.
Yeah. Okay. Now, people have tried different things. People have tried small pediatric Foley catheter, putting inside a pediatric Foley catheter, leaving it there for 4 or 5 days, and then taking it out. It is a little cumbersome, can be done. We have tried, we have left copper T inside so that the two walls, they do not. Lipis look would have been better because the surface area is much better, but that is not available nowadays. We can give estrogen and progesterone. We can give PRP, platelet-rich plasma, installation inside the, but that is not commonly used as a routine. The other thing what we can do, it is often difficult to convince the patient to do a repeat hysteroscopy, after 7 or 15 days. Now, this can be an office hysteroscopy. It doesn't require anesthesia. So, an office hysteroscopy. But this last point is very difficult for patients to convince. To summarize what I normally do, I put a copper T, I put them on estrogen progesterone replacement therapy, continuous estrogen and cyclical progesterone therapy for 3 months. Now, there are many papers published saying that whether you give estrogen or whether you do not give estrogen, it hardly matters. It hardly matters. Because physiological estrogen is already there. So for a woman with normal reproductive function, what are you going to do? But at the end of the day, we physicians, we feel good if we do something more. Now, people have identified some gel which can be pushed inside the uterine cavity after the procedure, and it is like that gel prevents adhesion of the two uterine wall. Most important thing is minimum damage to the endometrium. Minimum damage to the endometrium will actually prevent. So your surgical skill is very important, and that is why for a submucous intramural fibroid, I would rather do it laparoscopically, because when you do laparoscopically, you keep the endometrium intact. But if you do hysteroscopy, you have damaged that endometrium. Now, one technique of hysteroscopy is, instead of cutting the whole endometrium covering the fibroid, what you can do is you can make a small incision, and when fibroid pops out, you can scoop the fibroma, you can scoop the fibroid out of it. It's like having an egg, having a quarter boiled egg. You just break the top of the shell, and with the help of a spoon, you take it out. So you just think about that. The fibroid has a shell. You have cut a little bit of the top of the shell. So instead of removing the whole shell, then try to scoop it out. Now, with hysteroscopy, it's very helpful that you have scooped it out, and you take the hysteroscope out and again go in, you will find little bit has protruded. Because what happens is, if suppose this is the fibroid capsule, you have cut the capsule, the fibroid is going to come out through there. And uterus is actually pressing, the uterus is pressing and pushing the fibroid out. And in many of my patients, I've done submucous fibroid, removal of the submucous fibroid. Patient has come back after 3 months saying that still fibroid, small fibroid is there. So I was unable to completely remove. So nowadays I tell my patients all the time, resection of septum, removal of submucous fibroid can often be incomplete. That is not my limitation. That is the problem. Is like that. It is very difficult to remove it completely, because if I try to remove it completely, most likely I'm going to damage the uterine wall and damage the uterine blood vessel, and which is much more dangerous than an incomplete surgery. Of course, you have to do the next surgery free. If you charge again, the patients are not going to be happy, and you try the hospital as well to convince that it hasn't been completed. Like one of my relatives who is in the judiciary has said that if you cannot punish an individual twice for one crime, you cannot punish twice for one crime. Okay, so similarly, you cannot charge twice for a single treatment, and that is very important for surgery. I may be senior to many of the viewers here, maybe the same age, but my experience tells me that we can actually reduce the medical legal problem, and we can do on the patient side if we change our attitude. We have to think, what would have happened if it was my treatment, how I would have been, you convince a patient for a surgery, this is the fee, everything like that. Now after surgery, you come back and say, no, by the way, she has to require another surgery. So you should have mentioned it earlier. You should have mentioned it earlier, isn't it? Or you should have said, if she requires another surgery, I'm going to do it free. Okay.
Great, sir. Great. In fact, after every answer of yours, I feel that there is some particular practical textbooks or insights which I'm getting from you. And there is a lot of practical know-hows from what you are giving for every question. Thank you for that, sir. I hope, Dr. Chaudhary, you have got your answer for this question. So the next question again comes from Dr. Vandana Shah. She's saying, sir, how to manage multiple submucous fibroid?
Okay. Multiple submucous fibroid, you have to remove them. You have to remove them individually, hysteroscopically. We use hysteroscopy loop. Sorry, hysteroscopy by resectoscope. We remove them one after another, one after another. Now you have to remember that you are using glycine, and this glycine is often absorbed in the vascular system, and it causes a condition called TURP syndrome. So transurethral resection of prostate is TURP. They actually first identified this during prostate surgery, that many patients develop this problems of hyponatremia, hypokalemia. So glycine is fluid without electrolytes. So if it goes in your system, if it goes within the blood system, it makes the electrolyte level low. So patients often faint, patients often have convulsion. There are reports of blindness, temporary blindness. Now, how do you identify this? So I always do this surgery under spinal anesthesia. I don't do the surgery under general anesthesia. And I keep one of my assistants sitting at the head end of the patient and chatting with the patient, talking and chatting with the patient, and looking at the patient's face. Suddenly, if you see the parotid glands are swelling up, the eyelids are swelling up, you know that fluid is actually going inside the circulation. And if the patient is drowsy, not talking, I always keep an eye on the input and output. So how much glycine going in, how much glycine coming out. If the deficit is more than 500 ml, and if patients develop any of these symptoms, I will stop the surgery. I will definitely stop the surgery. I had this experience that during the surgery, patient suddenly said, I cannot see. And this is it, I got the shock of my life that, I'm doing a surgery and patient has become blind. So I went back, opened the computer and found that there are 2-3 cases reported. And with my luck, I had to be one of those cases. And this was a doctor. This was a doctor herself, an anesthetist on whom I was operating. But then I had friends across the country whom I telephoned, and they said, don't worry, it is temporary, it's going to be fine. I had several patients who had convulsion, got admitted in ICU. So I've become very, very careful that with multiple fibroids, I may not be able to remove all of them in one go. Whilst I'm removing them, if you cut too deep, fibroids don't have much vessel. But if you cut too deep, if you go into the myometrium, you open up the blood vessels, and this glycine will go inside the circulation and cause this problem. So multiple submucous fibroid has to be tackled hysteroscopically. You may be able to do it in one sitting, or you may require several sittings.
Thank you, sir. Thank you very much for this answer. So one last question from Dr. Divya Agarwal. Dr. Divya is asking, is hysteroscopy must?
Sorry.
I think he is lost.
Sorry. Can you repeat the question?
Yes, sir. Dr. Divya Agarwal is saying, is hysteroscopy must before each IVF cycle?
Well, it is in theoretically, yes, it is true, but practically we cannot do it. There are papers showing that if you do hysteroscopy in every individual, your success rate will be better. But it is published by one particular group. There are others who are saying it is not essential. Now, if you have a very good ultrasound department, if you have got 3D ultrasonography, many a time ultrasonography can pick up small problems. So in my practice, I do not do hysteroscopy as a routine for every patient before IVF unless I've seen some specific problem by ultrasonography. Unless I'm suspecting submucous fibroid or suspecting adhesions or some sort of Mullerian abnormality, subsepted uterus, T-shaped uterus, I usually do not do it. But having said that, once they have one IVF, then it is failed, then you have to offer them something new. You know, this is the normal psychology. So if you tell a patient, hysteroscopy before IVF, people don't agree unless you tell them a particular reason for it. If you say everything is fine, still I would like to do a hysteroscopy, immediately the patients will think this is an intention of earning more money. They will start doubting. They will start doubting. But if you do a hysteroscopy after first attempt failure, or she had one or two IVF elsewhere and has come to me, I would definitely do a hysteroscopy. Because there are reports, I've seen small flimsy adhesions, small polyp, tuberculosis, these are picked up by hysteroscopy. And once we correct them, many patients are very thin endometrium, not responding to therapy. You do a hysteroscopy and then often after the hysteroscopy, the endometrium is better. So answer to your question is, routine hysteroscopy is not required before every IVF, and it is not possible to convince your patient. But once you had failure, once you had problem, then definitely hysteroscopy is important.
Thank you so much for that answer, sir. We are very privileged to have you on our webinar series. We call our webinar series as Programming 28 Webinars. As I discussed previously, what is Programming 28? And importantly, this has been a very important webinar for us. This is our 75th webinar. And
75th?
75th webinar in last 3
months.
So
I'm so lucky to be the 75th one.
A very lucky number enough, sir. In fact, this is only my division under Mr. Rajiv Agarwal. We have done 75. Overall, MCAR must have done much more. But only my division has completed 70, and we are very privileged to have you as a speaker here. May I request Mr. Rajiv Agarwal, sir, to please give his closing comments.
Yeah, thank you, Dr. Amit. I am Rajiv Agrawal, and on behalf of MCure, I really thank Dr. Gautam Khastgir for a wonderful webinar, sir, and we are really privileged and honored to have you on your board. It is always treat and really pleasure to watch you, sir, and a lot of followers you have. And it was a wonderful, interactive, lot of question answer has been taken and very informative, sir. Once again, thank you from the bottom of the heart. And I also thank all the doctors who are patiently hearing this webinar and my team who has made this webinar very successful. And on behalf of MCure, I wish you a very safe and healthy life, sir. Wish you all the best. Thank you very much, sir. And thank you all the doctors, and thank you team. Thank you, sir.
Thank you very much. Thank you very much. Thank you, Rajiv. Thank you, Amit. And all the best. All the best to you and your family from our side. And I sincerely thank all the doctors for their patient hearing on a Sunday afternoon. This timing, I was thinking they should spend more time with their family, have a nice cup of tea and some snacks rather than listening to this boring topic. But I was glad to see so many of them are here. I tried to make it as lively as possible with my personal experience. But having said that, I had to rush through because it was a big topic. I'll be very happy to come back and focus on any individual aspects as per request of the audience. I'll be very happy to come and share, because sharing of the knowledge is the best thing we can do as a human being on this earth. And I finish by a statement made by my grandfather, who was also a doctor, who insisted that I should be a doctor. So he said that the most important thing of medicine is teaching. So you teach your patient, you teach your community, so they do not fall ill. They do not fall ill, and they do not need to come to you. And that is the most important thing. We have written many books in Bengali. We are now putting them in Hindi and of course in English as well. English books are available throughout the world. So many of these books are being highly appreciated in our community. So I've met many doctors and many patients who have actually said, by reading this book, it helped them, although they didn't come to see me. And you are doing a wonderful work with this webinar. And I think every event has a positive. So this corona infection, COVID-19, the positive thing is this more webinars we are doing, and it is giving us the opportunity of getting the knowledge in a relaxed position at our home. And I'm sure corona will be over, but we will continue this webinar. And the good thing is we keep this in record, so we can watch them again and again later and improve further. Thank you. Thank you very much once again. Thank you.
Yes, sir, one good news also I just wanted to share. MCure is also the company today got the approval for first human trial for the corona vaccine.
Oh, excellent. Excellent. Thank you. Many congratulations.
Thank you.
Many congratulations.
So
Well done.
Proud of this moment, and we are really proud that you are the part of 75th webinar for us.
No, that is very interesting, and I salute you for giving me this privilege or this honor.
We are privileged.
Thank you, sir. Thank you very much.
And I thank Brinal and Shomnath, who are the boys here. They are always there trying to help me and support me. And thank you. Thank you.
Thank you, sir. Thank you very much.
Thank you, sir. So with
Thank
your
you,
permission,
sir. Thank you.
Thank you, sir. With your permission, I'll now close the session. Thank you, participants. You can see this recording on IVA, IVF Virtual Academy on YouTube. Thank you.